Thank you very much for having me. So I'm going to sort of run through just really a bit of an overview of our organization, where we came from, and sort of, there's a lot to go through, so I do have some notes, so I don't get too sidetracked, and then we will just basically have some questions so that people can sort of hone in on things that are more relevant for you. It's always kind of hard to know what to talk about and sort of what type of an audience it's going to be. And, anyways, so my name is Andy Bond. I am currently the Senior Director of Housing and Program Operations with the PHS Community Services Society. What I'm going to do is give a bit of an overview by providing some history and context of how we've grown over the past 25 years, from being really the first model of housing first in Canada with about 10 units on one floor of a hotel into a large organization now, about $35 million of funding, and we're operating in 2 different cities now. With about 1,400 units of low barrier housing, a range of health services, including detox treatment beds, harm reduction programs, including Insight, which is North America's only supervised injection site, low threshold job programs, social enterprises, and a whole lot of other things. Some of the terminology I use may be different in the US, I'm unsure, so needs me to clarify what exactly I'm talking about, I'm happy to do that. What is the little advancer?
Clicker.
So, I was born and raised in Ottawa, Ontario, and I began working at the PHS after I had moved to Vancouver and been living there for only 3 days. So I've now been working with PHS for over 18 years. And having started in 1998, I've had the opportunity to gain experience across the full breadth of the organization. When I started, the PHS really just consisted of one project called Portland Hotel, which at that point had been operating for about 6 years. So I worked as a mental health care worker. That's sort of what we call the majority of our staff who are really working in the buildings, doing the work sort of day to day. We had just gotten 2 new buildings, so that brought us up to 3 buildings when I started, and I worked several years working night shift in a building, and that was really an eye-opening experience. And then as we sort of grew and started to try and fill gaps in people's lives, I was very involved in the efforts to open and keep open Insight. And then from there, I sort of worked in a variety of management positions, and for the past 9 months, I've been the interim executive director. We have a new executive director now, and I'm the senior director of housing and program operations. And over the past year, it's been interesting for us as an organization because we expanded to Victoria, which was dealing with sort of a really large tent city on the lawn of the provincial government courthouse, and we ended up opening a building and moving all of the people who were there into that building. And so generally the role that I'm in still continues to really be rooted in the community, and I'm still sort of interacting daily with the people that we have for so many years. And I guess the time I spent really working, which was about 9 years, working in the hotels at the front desk, for me it was shocking to see such a concentration of poverty and addiction after so recently moving from Ottawa. And every single person that I met had a story, And it was hearing these stories that sort of made me confront my own ignorance, my own stupidity, and my own fear. I think at the time I was rather naive, and I met people who were injecting drugs into their bodies, and my initial desire was to help them to get clean. I wanted to force people to detox. Surely they were motivated, and they clearly hit rock bottom. But working at the hotels and being immersed in people's lives and suffering really was an eye-opening experience. And just sort of, as people opened up and you began to hear people's histories of trauma, whether that was First Nations children who had been taken to residential schools, or severe childhood trauma, sexual abuse, a whole range of things. And I think it is important to sort of understand the context of the struggle in Vancouver. I think the downtown east side is fairly well known, but basically I'm just going to sort of run through where we were because the problems were so large, and that was sort of what forced us as an organization to really push for policy shifts. So the context of the struggle in Vancouver in the 1990s was a low-income community called the Downtown East Side. And this is where we began to provide services, housing, including Insight, where we were able to bring indoors the most marginalized at-risk drug users where they could inject safely out of the alleys and off the front doors of local businesses. Because eventually we were able to convince the people in our city that the lives of drug users mattered enough for us to shift our policies to keep them alive. The organization was started in 1991 by a woman named Liz Evans, and at the time she had been working as a psych nurse in acute care at the local hospital and was very frustrated by the sort of revolving door, seeing the same people coming in and out. Just really they didn't fit anywhere, they weren't getting better, they would sort of come into the hospital once they had really reached a critical point, they would spend some time there, they'd be released, and no one really knew what they were released to, usually it was back to the streets. And once it got bad enough again, they would go in again for a few weeks. And the social housing that was set up in the community was really for people who lived independently but who were poor. It was not for people with addictions or difficult behavior. The staffing models in those buildings consisted of workers who were really there for the physical building but not for the residents. And so during the sort of early days in the 90s, and even when I came in 1998, the situation was quite bleak, and the people who were coming into our housing were repeatedly referred to in the media as junkies, and they were told their lives didn't matter by the media, by themselves, by each other, and by the police. The community where people were using drugs and struggling to survive every day had a population of about 15 to 16,000, of whom close to 6,000 were injection drug users. So we faced a massive density of social problems. Involvement with the criminal justice system was rampant. We were surrounded by people who were isolated, at risk of violence every day, selling their bodies to buy drugs, suffering from third world diseases like syphilis, tuberculosis, and malnutrition while living in one of the richest cities in the world. So we really felt that we needed to do something different, and something that said people's lives mattered, and something that acknowledged our collective need for community, for acceptance, and for kindness. Something that told people they were human beings who mattered in the world. So in 1991, Liz, actually on her own for the first couple of years, opened one floor in a building called Portland Hotel, with the simple goal to house people who are unwelcome anywhere else. So the people brought in were struggling to find stable housing because they were experiencing desperate poverty, were often drug users, and many had mental health issues. We had a no eviction policy. And at the time, offering space to people meant offering acceptance. But what became clear was just how controversial this model was at the time, because we did tolerate drug use. And at the time, it was really seen as being crazy and irresponsible. And the concept of housing first has its origins in the late 80s and early 90s, which is more or less when the PHS was beginning. You certainly could not Google the concept at the time. I think the PHS is an example of when concepts are developing independently in very different locations. And I suppose that up until this day, we still, even in Vancouver, a lot of organizations have changed the way that they operate, but we still are rather unique in our ability to house very challenging individuals in numbers that continue to overwhelm a lot of the other housing providers. Yeah, so the first project was the Portland Hotel. And again, so we ended up, and I don't try not to drill it in too much, but it really is important to understand sort of all of the challenges that people were facing there. So the people that were coming in to this project, had a lot of mental illness. They didn't fit in group homes. They used drugs, presented with complicated behaviors in a building that was staffed by people who were there for the residents 24 hours a day, but who did not place any demands on the people who lived there to warrant deserving housing. There were no government programs or services set up to meet the needs of this group. And the complex population housed by the Portland in that hotel were representative of hundreds and thousands in the community, but the services were not set up for them. They were outside of all of them, and they were deemed undeserving. And once we really, just the level of problems was so high. So, there were things such as repeated infections and infectious diseases, no access to basic nursing care, medical care, or psychiatric care. There were people using a variety of drugs, sniffing glue, heroin, crack cocaine, smoking meth. People were just revolving through the criminal justice system for petty charges related to the sort of circuit they had been put on by their addictions. A whole range of mental health and neurological issues, everything from fetal alcohol syndrome, schizophrenia, plenty of people who had experienced extended childhood trauma, physical, psychological, sexual abuse, people coming from substandard housing, if any, the vast majority were homeless. And then, given the physical context of where we were and everything that was happening, we just decided that the best we could do was try to house people who were unstable and put an end to that cycle of homelessness. So we didn't know exactly what housing first was, but we were sort of creating it. So then, around 1998, once I came, at first the actual Portland had been controversial, and then it really did start to gain recognition from a lot of health providers, from hospitals and everyone else, because we really were stabilizing people, and they saw that there were 80% of people had lived longer in one address, and this was only after 9 months than they had in the previous 10 years. So that was quite alarming. The majority of people were in and out of jail, in and out of hospitals, that sort of thing. But once they were given a place and a home, then what? There was so much that people needed, and often, we couldn't provide everything, but we did what we could. And what was clear was, first of all, just providing space and being non-judgmental really had a big impact. And then we just started to sort of listen to what people were asking for. So if someone needed if they were having foot problems, we'd bring in a podiatrist. If they needed antiretroviral meds, we would have them provided, and started a med program in the building. If medical care was needed, a lot of the people were housing were barred from the 2 community clinics for past behavior issues, so we would work with doctors to have somebody come into the housing. When people couldn't get clean needles back then, they just had a 1-for-1 exchange. So we worked with drug users groups and really changed that policy, and so people were able to get them right at the front desk. Because on top of the overdoses and everything, the rate of conversion to HIV in the 90s in the downtown east side was the highest in the Western world, so it was on par with Botswana. So it was really, really bad, and a lot of it was because of people sharing meals. And I guess when we bring people into our housing, in each project we set up, we do try to see them as sort of micro communities that people are accepted into, not just as buildings. It's really important that we have the right staff that really philosophically understand the mission statement and are really able to do the work to put their own needs aside and figure out what's triggering them. If you don't have that, then the staff needs can end up taking over, and they start to have expectations of what they might want for people. It might be coming from a good place, but ultimately it might not be what that person themselves wants. So, we promote acceptance, and we work with the staff through a variety of ways and groups to really help people understand that we are all human with our problems, no different from the people we house, but that our role is to, not to allow our problems to get in the way. So if a person living, for example, with anger issues, because they've had a major trauma in their childhood, they might use rough language, but our challenge in keeping them housed is knowing that even if they shout at us, it's not actually about us. Although we do set limits and determine at what point we'll say I'd rather talk to you when you're not screaming at me. And we spent 20 years as an organization developing a language and a set of skills in how we train support staff to understand these principles, and that's really, really important. It is the key to us doing this work, and if we hadn't done this so many years ago, we never would have succeeded in stabilizing the lives of so many people. So we do have a fairly robust staff training plan, and I can talk a bit more about that later. And then sort of, moving forward into the year 2000, I'll go over after all the projects, we ended up sort of, really from 2000 to 2010 is when there was a really big expansion in services, because we just sort of started advocating for a whole range of things. But we, at this point, had about 5 hotels in about the year 2000. And sort of, so one of the, other big words and sort of philosophies that we were part of bringing on board in Vancouver and Canada is the harm reduction philosophy, which sort of grew out of our housing. So, as I said, we were very tolerant in our housing. We had a no eviction policy. And we decided intentionally to provide people without a home. Our goal was to provide space, and in doing so and being immersed in the hotels, we really saw, intimately the struggles people who use drugs were facing, and from this position, we recognized an urgent, desperate need to change. We began to argue for a different way to approach drug use through a policy shift. We argued that we needed something based on facts, not based on fear. Something that didn't ponder whether drugs were ideologically bad or not, but something that acknowledged what was really happening. Something that would improve public health, reduce overdose deaths, reduce the spread of HIV, and restore dignity. Such an approach, we argued, was pragmatic and cost-effective. So we really worked very closely on a lot of sort of public education and activist-type campaigns. Worked very closely with the drug users group in Vancouver, which is called the Vancouver Area Network of Drug Users. In 1998, we planted 1,000 crosses in Oppenheimer Park, which is the sort of main community park in the Downtown Eastside neighborhood, to represent those who had died of drug overdoses in the 4 years previous. We did a lot of, some blocking traffic and storming into council meetings and things like that, held banners, blocked intersections. But we also worked with experts in prevention, treatment, and enforcement to sort of recognize that what they were doing was very important, but there was just a piece missing for a lot of people. And we also really looked around the world at other approaches to drug use, in Europe particularly, where they had had a lot of success, and we just really tried to focus on the evidence, and because we had really been in this sort of criminalization and war on drug, very similar to the US, influenced by that, I would say. And in the year 2000, we had a big conference that we called Out of Harm's Way, where we set up massive tents in the park and had experts come in from all over the world and really talk about other ways to approach this. And that was when the concept of supervised injection was first brought up in our city, and at that point, politicians and the public began to take notice. And shortly after that, the city adopted what was called the 4 Pillars framework, embracing harm reduction as the 4th pillar alongside prevention, treatment, and enforcement. And the mayor struck a task force, and for about 2 years straight, we really worked with other groups and traveled around our city to community centers, to churches, all over the place, just talking about these issues. And public perception really started to change once people came to understand the issues better. And we really used every opportunity to get the message across. So, for example, when a whale died at the local aquarium, there was a lot of outrage. A lot of people went to have a big sort of mourning session for this whale. And we had a priest who was working in the neighborhood go on TV and just sort of remind people that people were dying every day in our community and nobody seemed to care. And eventually, because we did think it was really important the public understood this, there are some politicians who are brave and will go ahead of the curve and make things happen, but in our city we really felt we wanted to have the general public on side and supporting this. And so in 2003, Insight was opened, and it very quickly, within 2 months, some of the groups that were opposed, such as the Chinatown Business Association, so that's Chinatown and Downtown Eastside, are beside each other. Within 2 weeks, they changed their position. They immediately noticed a massive difference in the reduction of people using publicly. People are able to get clean equipment, nursing care. It has linked a lot of people to housing. 30 to 40% of the people that use the site are homeless. It's really been very beneficial, and we know that it's sort of meeting the needs of those it was meant to. It is the busiest supervised injection site in the world. It's been almost full since the day it was open. And I won't go too much into the sort of history and all of that, but we did, it was opened under a research grant, and then we had a change in government to the conservative government who were very ideologically opposed, and we ended up having to fight the government in court, which was scary for us as a nonprofit, and it ended up going all the way to the Supreme Court of Canada, where they ruled unanimously that it would remain open. But immediately after that ruling, they introduced a new bill that made it basically impossible for anyone to open any more injection sites. And so I know, it's great that sort of the conversation in our country, in some degree here, has really picked up around this service. I mean, it is, I found over the years, I guess, that it's a subject a lot of people like to shy away from because it just makes people uncomfortable. But what we've seen is that everywhere that these services are proposed, it's a lot of pushback from sort of neighbors or people not, it just sounds very strange to people at first, and you get a lot of comments about how you're just enabling people. And I do understand this is a challenging health and community issue to make sense of, and it does make a lot of people uncomfortable, but everywhere the service is established does see this significant improvement in health outcomes, including the ability to connect people to recovery and detox. So there are a lot of people that are always scared about sort of what message this sends to the youth, or claim that we're just enabling people, and that is a sort of constant refrain. I'm very used to going to community meetings and talking about this, and those sort of things come up, that somehow by having a space where you allow drug use, you're celebrating drugs. And what we always say to that is no, nobody is celebrating drug use, but we are celebrating the lives of the people that are stuck in really awful situations. And that we have an obligation to not just look at that individual person's responsibility, but our collective responsibility about what we have failed to allow this problem to become so endemic. In the 18 years I've worked in the downtown east side, for example, I don't think that I have met a woman who is an IV drug user who hasn't experienced sexual violence, who is an addict, along with just so many other traumas. So we're really not talking about people who just woke up one day and decided to go become an injection drug user. For most people, that's not their story. I think we've mixed up some really basic things. And it's it's a well-proven scientific fact that IV drug use is not a random action or a free choice issue. It is embedded in suffering, and it's just one of the ways people choose to cope, but we have not created enough pathways out of that lifestyle for people to find hope and healing. And so then there's a number of other programs that don't get talked about nearly as much. So after operating Insight for a few years, we opened something called Onsite. So that is, the building that Insight is in has 3 stories. So right above there is a detox program floor and then a transitional housing floor. So again, when we went to the health authority with that idea, they thought that we were crazy and why do you want to put a detox on top of an injection site? But we're seeing so many people come into the injection site who weren't able to get into detox. It was really difficult, or there were wait lists that were unrealistic, and in a certain moment they would just really want to go to detox. So we opened that, and it's now become the most successful detox in terms of stay for people in the neighborhood. Also, some of the detoxes had weird rules around if you failed in the detox, you weren't able to return for 6 months or something. We thought that was strange. And it is proven the more times people go back, the more likely they are to succeed. So, and for some of the people that were really entrenched, it was just a bit of a respite to sort of, even if it was for a week, they could really get some medical attention, maybe get hooked up to some kind of housing if they were homeless. But there are many people as well that have really succeeded in that program, and so that has worked really well. Needle exchanges, we run in one of our ground floor, a 24-hour-a-day needle exchange. That is the busiest needle exchange. There's a lot of equipment and naloxone training for the community, that type of thing. We also have a mobile needle van. There's actually 3 of them, so they drive around the city. If anyone calls a hotline, if they find a needle anywhere, we'll go pick them up. We also work with the city of Vancouver, so people can phone the city's 311 line and just report the needles, and we'll drive around and pick them up. CTCT is a program on one floor of a building, it's a small program, but that's for people that are on IV antibiotics, and they have in the hospital about a 56% success rate of finishing through with the program, and these are quite severe infections. People are going to lose a limb if they don't follow through, that type of thing. And so what we did is opened up one floor in one of our hotels and immersed it in the community, and people can stay, as long as they stay on the IV program, they can stay in the building, and it's had a 98% success rate. There's only one person I know of, it's been about 10 years now, that hasn't followed through, so they are able to come and go as they want. A lot of times at the hospital, it was, the hospital's sort of out of the neighborhood, it would be people returning to maybe use drugs, or just behaviors the hospital couldn't deal with, so they would end up getting kicked out often. Pennsylvania Supported Suites is another just one floor, 9 people. That's very, very high needs, 24-hour nursing care, but again with the same sort of set of addiction issues and mental health. We have Narcan training that we do at something that's called the Drug Users Resource Center. In the past 12 months, we trained over 1,500 peers on how to administer naloxone. We also, because the needle van was swamped, started something called Spikes on Bikes, which is a peer-driven program that drives around on bicycles and actually picks up needles in alleys, and they also carry naloxone. And then managed alcohol programs as well, so that was the same thing for a lot of illicit beverage drinkers who are drinking hand sanitizer and such. We have a variety of, some of them are highly medicalized programs that are very closely monitored, and then we have one that is in the Drug Users Resource Center that's more of a brew co-op, and people sort of put their money in, or they trade illicit beverages, and we actually keep them all, so we have just barrels and barrels of this stuff that people would have been drinking otherwise.
Forgive me, a question.
Yeah.
When you have illicit beverages, I'm not sure what you're referring to.
Oh, that's like hand sanitizer, rubbing alcohol. Yeah. So people that are drinking, and it's quite severe. We definitely see quite a lot of that. It's definitely, there's been a lot of managed alcohol programs that have opened up, so the idea is to get people off of that. It's a challenging program, because when you're dealing with people that have been chronic alcoholics for so long, their body is already in decline. So it can be hard even for staff sometimes, because you're still giving them alcohol, and they're still going to keep declining, but it's going to slow that down. And again, there's so many studies on these showing the benefits of or wine or something instead of the other stuff. Yeah, so then another big sort of piece that we developed was a lot of peer engagement social enterprises, because as people were stabilizing so much, and a lot of other organizations also were working alongside us on this, not quite, sort of following behind, but there's an organization called Rain City that are very similar to us, and we're, really aligned. They weren't as activist in nature, really pushing the things, but very similar mandate. And really, as we were having so much success, by this point we had about 6 hotels, and you could really noticeably see the difference in the community. A lot of other providers were changing the way that they operated and trying to be more flexible and that kind of thing. And as people stabilized, we really saw a lot of people that needed something to do. Many people were still living with addictions, but they were managing them much better than they were. So we really have a wide range of job opportunities that we've developed over time. So one of them is something called East Van Roasters. So this is a fairly nice looking coffee shop. And it's located in the downstairs of another building that we ended up opening in about 2008 called the Rainier Women's Treatment Center. So that's the only treatment center for women living in the downtown east side. And sort of this coffee shop's in a retail space on the ground floor, and they do bean to bar chocolate as well as coffee roasting, because bean to bar chocolate's a very labor intensive process. But so it's easy to create jobs where people can just drop in if they need some money, right up to sort of full-time employment. So we do have some people that live in the hotel, work there full-time. And it's sort of it's a more dignified environment. A lot of people like it. A lot of the jobs that are given out are sort of, to the peers and drug users, are usually picking up needles or cleaning streets or that type of thing. So it's nice. A lot of people really enjoyed that program. We also, there's a whole range of social enterprises, and I don't want to spend too much time going through them all, but we have an art shop and an art gallery that were just there were so many people creating art and there was nowhere for them to show it, so that's an art gallery right in the downtown east side, as well as a store where people can sell their art on consignment. We have a program called the Downtown East Side Central Kitchen, which there is now, but there was not a lot of food in the hotels, so we sort of pooled together some resources from one of our buildings had a commercial kitchen, so we actually now prepare 1,200 meals a day there. There's one PHS staff that oversees it, the rest are all peer-based jobs, and then we have something called the Lunch Peddlers. We have about 12 bicycles with trailers, and they basically put the meals into the trailers, and then peers drive them around to our 14 different buildings each day, and then they drop it off, and everyone gets at least one nutritious meal. That was an interesting one because they did a lot of research when we first started it at sort of 3 most challenging buildings where people really were not eating a lot, and there were a bunch of immediate outcomes, and one was the decrease in 911 calls that dropped in half, which makes sense. People are hungry, you're agitated, it's a